I am Dr. Akshay Halkude, Assistant Professor, Department of Orthopedics, SSIMS and RC, T. Begur. Today we'll be talking about fracture classification and fracture healing. We see a lot of cases in our day-to-day activities involving the fractures. So it might involve the fractures of the upper limb, lower limb, around the hip, spine. So these fractures might occur either by a trivial fall or following a road traffic accident, which might be either a high velocity injury or low velocity injuries. So what is a fracture? A fracture is a break in the continuity of the structure of the bone. So traumatic injuries account for majority of the fractures. So how does a fracture occur? So injury is the most common mechanism for any bone to fracture. So it might be either direct or indirect cause of injury. So when there is a direct injury at the fracture site, there will be involvement of soft tissues. Whereas in case of indirect injuries, it might be either due to compression or bending force, or there will be a tension or a twisting force. So other mechanisms of injury are repetitive stress, usually undisplaced fracture, seen mostly in athletes or old age people, and abnormal weakening, that we call it as pathological fracture. So here are few examples. So this is due to a compressive force in a pediatric age group. So this is the distal end of radius and ulna. We see a fracture line here. This is caused due to compressive force. And this is a bending force. So there is fracture on one side, whereas another cortex is intact. And this is an avulsion type of injury, which is around the elbow joint. This is the fracture of the olecranon caused due to pulling of the triceps muscle. And this is called as avulsion injury of the tibial spine. This is seen around the knee joint. And this is an avulsion fracture of the base of the fifth metatarsal, that is involving the foot. And the rotational injuries or torsional injuries cause what we call it as spiral fracture. You can see the fracture line is not a horizontal or an oblique, it is a spiral. So this is mostly commonly occurring in cases when there is a torsional injury or rotational injury around the bone. So how do we classify fractures? Fractures are classified on the basis of etiology, based on the displacement, based on the whether a fracture is communicating with the external environment, the site of the fracture morphology, whether it is transverse, oblique or spiral, and based on the stability. So on the basis of etiology, it may be either the cause of the fracture, it might be either traumatic, atraumatic, pathological, a stress fracture or insufficiency fracture. So what we see here is a pathological fracture. This is a fracture in the subtrochanteric region of the femur. So this is a pathological fracture because this is a highly weight bearing region in the body, and the fractures around this are usually either pathological or in a high velocity injuries. And this is a fracture, what we call it as base of second metatarsal fracture, what we call it as March fracture. This is also a stress fracture, and this is an fracture of the neck of the femur caused due to loser zone. What we call, there are blood supply around the neck of the femur, and there is progressive weakening leading to fracture around the neck of the femur. And here's another example. This is what we call it as fracture around the neck called as loser zone. So the blood vessels wind around the neck of the femur, and when there is pathological weakening, these kind of fractures occur in either trivial form or even if there is no trauma, there is sometimes a fracture. On the basis of displacement, what we call it as undisplaced or displaced. The displacement might be either a slight angulation or complete translation of the bone, or there might be a rotational deformity, or the length might be altered. There might be either lengthening or shortening of the bone. So next is, so this is how an undisplaced fracture looks. The proximal and the distal segment both are almost at the same level, but there is no or minimal displacement, what we call it as undisplaced. These fractures can be either treated conservatively or with surgical management. And these are what we call it as angulation fractures. Based on the mechanism of injury, the bone might either get split, so there might be an angulation. So instead of being straight, there is an angle. The proximal and the distal fragments are at an angle. It might be either acute or obtuse or depending on the angle. So this is a fracture of the humerus and this is a fracture of the clavicle. So based on translation, here we can see there is anterior as well as in the sagittal as well as in the coronal plane there is translation, and this is a completely displaced shaft of femur fracture. So again what we say is rotation. So in the earlier segment we saw there is translation, but in this the proximal and the distal fragments are completely rotated. So they are no longer like this but rotated. In a three-dimensional view, what we can say, all the three cortices are not in shape but they are rotated. So that we call it as rotational type of fracture. And next what we call it as length. So in this shaft of femur fracture there is very much shortening of the bone fragment. So almost the distal fragment is moving upwards and this leads to shortening of the bone. So other classification is on the base where the fracture is communicating with the external environment. So when a fracture communicates to the external environment, what we call it as the bone fragment pierces the soft tissues and is exposed to the environment, outside environment, in case the skin is broken. So this is what we call it as open fracture. In case if the skin is intact, it is called as closed fracture. So here is an example. There is a fracture of distal end of radius, but the skin is intact. So it is a closed fracture. On the other hand, we see what we call is a shaft of tibia fracture, whereas the bone and the complete soft tissue is exposed to the outside environment. So this is called as open fracture and this is a closed fracture. Based on site of fracture, we divide it in pediatric age group in the epiphyseal, metaphyseal and diaphyseal. So epiphyseal is close to the joint, metaphyseal is below the joint, whereas diaphyseal involves shaft of the joint. So we divide it into upper, middle and lower one-third or distal one-third of the diaphysis. So in adults we divide it into intra-articular, proximal, distal or shaft. So here are few examples. So these are the parts of the growing bone. This is a pediatric bone showing the distal end of radius, ulna and the wrist joint. So this is the epiphysis, this is the physis, the transparent line. This is part is the metaphysis and this is the diaphysis. And these are few examples where there is a fracture around the metaphysis of the distal femur in a pediatric age group. How would you say it is a pediatric age group? The physis is not yet closed. So the bones are still growing and the physis are not yet fused. And this is a fracture in the metaphyseal region of the distal tibia in a pediatric age group. So in adult, what we call it as proximal one-third, middle one-third, distal one-third, and these two are the articular surface. This is an tibia shaft, normal anatomy. On the basis of morphology, we divide it into either transverse. So this is a transverse fracture, this is an oblique, spiral, comminuted and segmental, where in a single bone at more than 2 levels there is a fracture, we call it as segmental. And avulsion fracture usually we see when there is an attachment of a tendon, ligament, when it pulls out of a bone, that leads to an avulsion fracture. An impacted fracture where a part of bone is crushed into the native bone. And torus fracture where there is incomplete break on one cortex whereas complete break in the other cortex. So there will be bending of the bone. This is seen in pediatric age group. And green stick is also a type of torus fracture. On the basis of stability, we check if the periosteum is intact, then we call it as a stable fracture. So the fracture does not move much. In case of unstable, there will be gross displacement and periosteal disruption of the fracture site. So here are few examples. This is a fracture of the both bone forearm in a pediatric age group. It was treated conservatively with close reduction and cast application. The periosteum is thick in pediatric age group, but it might not be much disrupted. So we can treat it conservatively in case of pediatric age group. Whereas in an adult, this is what we call it as comminuted fracture of the distal one-third tibia and fibula. So this is a segmental fracture and this is a comminuted fracture. These cases cannot be treated conservatively, because if we treat conservatively, then the time required for healing takes long and weight bearing for the patient is delayed. So we treat with surgical management. So next we go into the fracture healing. So any fracture anywhere in the body will heal. Either the body tries to heal naturally, or sometimes we as orthopedicians, we make sure that the fracture unites either by treating it conservatively or surgically. The main aim of treating a fracture is so that the fracture unites well and the patient is able to mobilize as early as possible the affected limb. We don't want the patients to be immobilized for long. That is the main goal of any orthopedician. We want the patients to get back to their activities of daily living or carry out their own activities as fast as possible. That is the main goal of any orthopedician. So, what are the types of fracture healing? There are primary healing, secondary healing, and distraction osteogenesis. So, primary healing we call it as direct healing, and secondary healing is also called as indirect healing. In primary healing, it resembles the normal remodeling of the bone. So, it occurs only when there is anatomic reduction of the fracture site. Let's say you take a piece of paper and you join it. Sometimes we don't see the line where the paper was torn. So in that case, if we are able to reduce the bone anatomically, so that leads to primary healing. So it occurs when there is anatomic reduction and with rigid fixation. So rigid fixation implies there is not much of movement at the fracture site. So this allows for direct contact areas heal by cutting cones allowing passage of blood vessels. So when there is a fracture, there are blood vessels at both the ends. When there is direct contact, so the blood vessels pass easily and that leads to primary healing. So gaps in the reduction heal by vessel ingrowth, mesenchymal cells, osteoblasts and osteoclastic activity and cutting cones. So in case of direct healing, the callus is not seen. So callus is, we'll discuss later on what is a callus. And in case of secondary healing, so here is one example of direct healing. You can see there is not much of callus and there is anatomic reduction. So this will heal by direct healing. Whereas in case of secondary healing, there is periosteal reaction. So external soft tissues are also involved and there is some amount of bridging callus. So extra bone is formed around the bone, what we call it as callus, periosteal bridging callus. So there is intramembranous or there is peripheral to the fracture, there is some amount of callus. Enchondral is adjacent to the fracture, motion enhances periosteal response. So you can see in this example, other than the original bone, there is some amount of extra bone formation around the fracture site. This is called as callus formation. This is a form of secondary healing. So next we'll go into the stages of fracture healing. So there are 5 stages. The first one is the tissue destruction and hematoma formation. So whenever there is a break in the bone cortex, there will be some amount of inflammation, cellular proliferation. So we'll tell the stages. Cut. Stages of fracture healing: tissue destruction and hematoma formation, inflammation and cellular proliferation, that is stage 2, and stage 3 is callus formation, stage 4 is stage of consolidation, stage 5 is stage of remodeling. So what happens in stage 1? There is tissue destruction and hematoma formation. So this usually is seen around 1 to 2 days, where the torn blood vessels around the fracture site, they bleed into the fracture site, what we call it as hemorrhage. So the mass of the clotted blood, hematoma forms at the fracture site. So the fracture site usually becomes swollen, painful, and when you palpate, there is some amount of tenderness. So histopathologically, it is seen like this. So this is the bone, there is periosteum, and these are all the hematoma formation. So second stage is the inflammation and the cellular proliferation. So this is usually it starts within 8 hours of injury and it is continued for the first week. So from around 2 to 7 days this occurs, and there is proliferation and differentiation of the mesenchymal stem cells, and there is secretion of tissue growth factor beta, platelet derived growth factor, and various bone morphogenic proteins. So stage 3 is the callus formation, what we call it as. When the inflammation is initially, it triggers cell division and angiogenesis. Angiogenesis is new vessels formation. So initially the vessels are torn, and as and when the healing proceeds, there are new vessels forming, what we call it as angiogenesis. So in this stage, the chondrocytes or the cartilage forming tissues, they secrete collagen and proteoglycans. So capillaries or the new vessels grow into this fracture site, and the phagocytic cells begin cleaning out the dead tissues or the dead osteoblasts. and the new bone which is forming, or the new tissue is forming, what you call it as granulation tissue, and this leads to the formation of soft callus. And within the few days, the sticky ends are formed in the bone which called it as callus. And the fibrocartilage, after this soft callus, it leads to fibrocartilaginous callus formation. So this is how it looks. Initially the torn periosteum is getting repaired and the hematoma is as usual, and the dead tissues are removed and new osteoblasts, capillaries and angiogenesis are in. This is a histopathological slide of a fractured bone. So in stage 4, now the stage is set. So there was hematoma formation, then new bone formation, angiogenesis, and everything is done. So it has to become stronger now. So what we call it as next is the stage of consolidation. So the new bone or trabeculae. Trabeculae are formed in the normal bone. There is some amount of trabeculae, and this has to be formed again in the fracture site. So there is new bone trabeculae appear in the fibrocartilaginous callus. So the fibrocartilaginous callus is soft. So it is then converted into the hard callus. Initially what we call it a soft callus, then it is converted into a hard callus, and it usually begins by 3rd to 4th week, and it continues until the complete union is formed within 2 to 3 months. Next is the stage of remodeling. So now the bone is formed, it was initially soft callus, now it is a hard callus, but still there are chances that if the patient is bearing weight or some excess stress is applied, there are risks of fracturing. So what happens, the bone has to heal, it has to come back to normal physiology. So the last stage is the stage of remodeling. So the excess material on the bone, or whatever the hard callus was formed on the shaft or in the medullary canal, this is removed. This is by osteoclastic activity, and this allows bone to assume its normal configuration and strength. So the compact bone, woven bone is initially laid down, that is later converted into compact bone, and it reconstructs the shaft walls. So the stage of fracture healing is not in a set. It does not happen like one stage is finished, then moves on to the second stage, then third, and then fourth, and then fifth. So it is usually overlapping. Usually as the first stage starts, then the second stage starts on its own. Some part of the bone is still in the first stage, some part of it is in the second stage, then second, third, then third and fourth. So some amount of there is overlap. It is not a specific set of stages. So this is how, when we follow up a fracture case, this is how it looks. This is a pediatric case. There is a shaft fracture, and later this is secondary healing, by the way, because we can see a callus, and then there is stage of hard callus formation, or then there is stage of remodeling. So distraction osteogenesis is one more form of bone healing, which is usually as done by orthopedicians, and it is a biological process of new bone formation between the surfaces of osteotomized bone segments that are separated gradually by incremental traction. So what we do is, when there is bone loss anywhere in the body, we transport the native bone, we make a cut on the upper part, and slowly we bring down the normal part. So it is docked into the distal fragment, and this leads to new bone formation and complete bone recovery. So this was started by Elizarov in the 1950s. So lengthening limbs through gradual distraction of the fracture callus. This is the principle based on distraction osteogenesis. So what is biology? There is, it is divided into 5 parts: osteotomy or corticotomy, latency phase, distraction phase, consolidation phase, and the remodeling phase. First is the osteotomy phase, where we divide the bone. So there is one fracture site, proximal and distal fragments. So in the proximal fragment, what we do is we make a cut in the bone. So that is called as osteotomy. It is divided into 2 segments, proximal fragment, and this triggers bone repair, angiogenesis, fibrogenesis, and osteogenesis. This happens in the osteotomous part, that is done by us. So in the latency phase, what we do is we allow the bone to form again. So whatever fracture healing we have seen the process, that is allowed to be formed at the osteotomized phase. That is allowed for up to 1 week. So the period begins from the division to the onset of distraction. So this stages goes through the latency period is around 5 to 7 days, when there is some amount of soft tissue callus formation. So this is how it looks after an osteotomy until the granulation tissue forms. And third is the distraction phase. In the distraction phase lasts from 1 to 3 weeks, wherein continuous traction. So what we use ring fixators, we use it to distract the bone. So after the osteotomy, the bone segment that is left out is distracted each day from the osteotomy side distally towards the fracture side at 1 mm per day. So we do it for every 6 hours. So 0.25 mm, it is distracted every day. Or it can also be done for 0.5 mm every 12 hourly. So here's one example. So initially distraction, this would have been the corticotomy site, and once after the corticotomy is done, 1 week we leave it so that the fracture healing is formed. Then slowly 0.1 mm per day we distract the bone distally. So this is new bone formation, and this fragment can be docked into the fracture site. And then what we call it next is the consolidation phase. So once the bone is docked to the distal fragment, the traction forces are removed. So the distraction is stopped. So once we stop the distraction, there is formation of lamellar bone in the corticotomy site. The bone length is mentioned, and the distal fragment is docked into the fracture site. So this is how it looks. There is during the consolidation phase. This was initially, you can see there is some amount of woven bone, and as it consolidates, there is lamellar bone being formed. And next is the stage of remodeling. So the distraction, whatever we applied, the ring fixator, that is removed, and the formation of the lamellar bone is allowed to continue. So this is how it looks. So this is the new bone formation. You can see plenty of callus, and there is adequate remodeling. So this is a summary of what we call distraction histogenesis. This is a normal bone, or there might be some amount of anomaly or this bone loss. Let's say limb lengthening is required. What we do is we perform a corticotomy in the bone here. So slowly this segment is distracted down, and this leads to bone lengthening. This can be used for lengthening of a limb, or in case if there is a bone loss, it can be restored using this distraction osteogenesis. So next we'll deal with what are the factors affecting fracture healing. So it depends on the fracture type, whether it's an open fracture or a closed fracture, the condition of the gap, if the gap is too much or too more, and fixation rigidity. So fixation rigidity depends on, the bone healing depends on fixation rigidity. If it is a rigid anatomical fixation, then the bone heals by primary healing, if not by secondary healing. And loading, whether the forces acting on the fracture site are high or low, and biological environment. So biological environment or homeostasis of the patient. So the biological factors are age. Young age patients usually heal well. Old age patients, due to their physiological status, take a long time for the fracture to heal. Comorbid medical conditions such as diabetes mellitus, hypertension. Functional level, highly functional people usually heal, take a shorter duration to heal, whereas people with low functionality will take a longer time. Nutritional status, vascular injury, hormones, growth factors, health of the soft tissues around the fracture, smoking, pathological conditions, and extent of bone loss. So the mechanical factors, high energy injuries usually take a longer time to heal, whereas low velocity injuries, shorter time to heal. Bone loss, if more, longer time to heal. Soft tissue attachment, good prognosis. No soft tissue attachment, poor prognosis. And anatomic location of the fracture. So usually non-union we see in cases of fracture around the neck of femur, or scaphoid fracture, or epicondyle, where the forces acting are continuous and don't allow the fracture to heal. So growth factors such as transforming growth factor beta, bone morphogenic proteins, platelet-derived growth factor, fibroblast growth factor, insulin-like growth factors, all of this promote fracture healing. So osteoinductive mesenchymal cells induce osteoblasts, which regulates cartilage formation and bone formation, and it induces mesenchymal stem cells and osteoblasts to produce type 2 collagen, and which promotes cell proliferation and bone matrix synthesis. Chondrocytes and osteoblasts and all this stimulate bone formation. So it promotes proliferation and differentiation of mesenchymal precursors to the osteoblasts, stimulates the enchondral and intramembranous bone formation, induces synthesis of cartilage specific proteoglycans and type 2 collagen, stimulates collagen synthesis by osteoblasts. So local regulation of bone healing is by growth factors, cytokines, prostaglandins, hormones, growth factor, growth factors. So these are the few growth factors, which is platelet derived growth factor. There are A and B, and it increases type 1 collagen synthesis by increasing the number of osteoblasts, whereas platelet derived growth factor B stimulates bone resorption by increasing the osteoclasts. So insulin like growth factors are 1 and 2, which is synthesized by multiple tissues, and insulin like growth factor 1 uh, is production is in the liver, stimulated by growth hormone, stimulates bone collagen and matrix synthesis, stimulates replication of the osteoblasts, and inhibits collagen degradation. So cytokines we have 1, 4, 6, 11, and granulocyte and macrophage colony stimulating factors, TNF tumor necrosis factor, and interleukin 1. So here's a brief summary of what the bone forming and bone resorbing factors are. So interleukin 1 is more bone forming, whereas bone resorption is more. And as we go down, the bone formation capacity of increases and bone resorption capacity decreases. So prostaglandins, leukotrienes, it depends on the species. Effect of bone resorption is species dependent. Prostaglandins or PGE, what we call it as prostaglandin E. So it stimulates osteoblastic bone formation and inhibits the isolated osteoclasts. Leukotrienes stimulate osteoblastic bone formation, enhance capacity of isolated osteoclasts to form resorption pits. So hormones, estrogen stimulates fracture healing through receptor mediated mechanism. Thyroid or thyroxine or triiodothyronine stimulate bone resorption. So glucocorticoids inhibit calcium absorption from the gut, which delay the bone healing. So parathyroid hormone in intermittent doses stimulates bone formation. Growth hormone mediated through insulin-like growth factor increases callus formation and fracture healing. And angiogenic factors, these improve angiogenesis and leads to bone formation. So newer therapy such as electromagnetic field. So there are certain papers that show that when an electromagnetic field is applied around the fracture site, there is some amount of bone formation or new bone formation that enhances fracture healing. So these are still controversial and still studies are being done. So ultrasound, what we do is low intensity ultrasound is provided to the fracture that stimulates, this is done in usually fresh fractures, and this increases gene expression for growth factors. This increases blood flow, increases callus formation, and these are also studied in animal models. Thank you.